So thanks, Julie, for that introduction. Yes, indeed, I have been a transfusion practitioner now for 20 years. And I have to say, with 24 hours notice for this talk, but I didn't write it in 24 hours. I'm not that good. Last year, I was invited to speak at Blood 2022 in Sydney in Australia. And this was the topic they asked me to talk about. So I make no bones that I've just taken the same talk and repeating it 6 months later. I'm not here to tell people what to do in terms of being a TP in patient blood management, because that's what we do all the time. So think of this talk as me just pulling together some thoughts and some ideas about what we do as a TP and when it comes to PBM. And, 20 years ago, we weren't talking about patient blood management when I started, but we're nothing if not adaptable. And so as PBM has increased and the whole part of PBM in the transfusion world has increased, so transfusion practitioners go with it, because that's what we do. But let me just make sure I can move this on. Transfusion practitioners are not born, we're made. And it really is an umbrella term. And working within ISBT, we spend a lot of time just saying that transfusion practitioner is a term we use. And you can see that when we wrote this paper in 2020 for Vox Sanguinis about transfusion practitioners, we synthesized all the names that we got and made them into this list. So we know, even on this call, that different people have different names, but just think of TP as being that overarching title. And what I love about the TP role, one of them is the fact that we do from such a diverse background, science, ODPs, midwives. So TPs, we're here, we've been around for a long time, and we do a lot of things for a lot of people when it comes to blood transfusion. And this is probably my favorite slide, not this one, the next one. There we go. Which I use in all my talks, because to me, it sums up us. We are in the middle of the whole transfusion world, from internal relationships. I'm going to look at this in a little bit more detail further on, to the external relationships. Everything has a transfusion practitioner at the center of it. And it doesn't matter whether you're talking about patient blood management, or whether you're talking about hemovigilance, or you're talking about training and education. When it comes to things we do in transfusion, this is where the TP sits. So how did I get to talk about patient blood management and transfusion practitioners? Well, I wrote this paper with a colleague from Australia, Lindley Bilby. She is the lead in the ISBT TP group. I'm her very willing deputy. And we wrote this because we wanted to show that the TP role really came from that safety and hemovigilance culture. But actually, we're not talking about safety so much as blood safety now, but much more about transfusion safety, and how this PBM is all part of that shift now, as we're moving far more towards a patient-centered approach. But where does the TP, and the great other thing, you see, I'll say that a lot, I'm very impassionate about this job, 20 years on, but not everybody's been around for 20 years. Some of you have been around for a year. And particularly the nurses will be very familiar with Benner. Pat Benner is something as nurses we learn from the beginning of our time. And it's the novice to expert. And very straightforward. As a student nurse, you are the novice. And I think as I get 20 years down the line now, I'm an expert at being a transfusion practitioner and a nurse after 30 odd years. So we can use this very easily into our transfusion practitioner model. And looking at where we sit as TPs. So we've written this for ISBT. It is available on the ISBT website. And we've split it. We've not done the 5, we've done the 3, from novice to experienced and senior practitioner. Now, within that, you can see we put all the key components. And this is where I go back to the title. The title really is irrelevant. It's the components of the role that make it so critical. And all these components, whatever we're doing, sit in our role. Some greater and lesser to extent, but nevertheless, I believe they're there. And we have looked at patient blood management in some detail. And on the next slide, I'll just highlight some of what I think are the critical points. But again, looking at it from a novice through to a senior transfusion practitioner. So what do I think? Well, I think even as a novice, you're looking at the gaps. What are we doing well? what needs a little bit more work, things like wastage, single unit. We're talking so much today about PBM projects and what just Kat's just been talking about. So we can do that at a fairly early on in our TP world. And of course, resources are a huge part of what we do. As you become more experienced, you're becoming more collaborative, perhaps a little bit more of a liaison process, and then looking about audits. And then as you become more senior, you're doing all these things, but it's much more about the facilitation and synthesizing the information and working with people. And we've heard beautifully from Denise about how working as an MDT was so critical to her project. Now, patient blood management kind of hit our screens 2014, I think now, from MBTC. I remember when it came out. The definitions, we've already heard from Prof. Shanda earlier on about a global definition. These were the definitions that came out of NHS England, what's that, 9 years ago. And it's fairly simple. I like simple and I like straightforward. So what, of course, we wanted to know, what are we going to do as a TP? So this is what they put in as our responsibilities. And you can read this. Many of you will have seen it. Many of you will have incorporated it into your job descriptions, because indeed that's what it is. That is my job description. Since 2003, I've been doing transfusion incidents, hemovigilance data, audits, developing working relationships. So it really wasn't anything new, PBM, for us. We were already doing it. Now, all you have to do is Google 3 pillars of PBM, and this is what you get. Everybody has their own. In Australia, when I did this talk, I used the Australian ones, when in Rome, but they all mean the same thing. What are they looking at? They're looking at optimization of the patient's own blood, minimizing blood loss, and then optimizing the patient's physiological tolerance of anemia. And that's what we do. That's what we want to happen. Now, as this talk was written for Australia, I had to talk about the PBM modules. And if you haven't seen these, I highly recommend them to you. They are all available as a PDF download. Obviously, working at Great Ormond Street, I'm all over the neonatal and pediatrics one. And when in Australia, picked up a hard copy and threw that in the suitcase. But the others are excellent, and I can't recommend them enough. They're very good. So this is what we recommended when we came up with our recommendations in 2014. Lots of information. Many of you have seen this before. But what we need to look at is, where does the TP sit in all that? And that's the point of this. Where does the TP fit into this whole PBM picture? Well, one of the things I feel very passionate about, and going back to my favorite slide about where we sit, is it's an MDT approach. It's a team effort. You're all familiar. Something comes up to the chief executive or the medical director, even the shortage last year, says the word transfusion, and next thing you know, they're forwarding it to you, as if nobody else is interested in transfusion. So the trick for me is to be in the center of it all, to be right in the middle of it, but I'm not there to do the projects. And I think, again, with some of the things we've seen today, these talks from Helen and from Kat and Denise, it's all about, and the Harefield talk as well, it's all about other people taking ownership, not just the TP. But we need to build on these key relationships. Nursing. PBM is starting on the floor with the wards and the patients. It's not some high level sitting at the upper echelons of the trust. So building relationships, work out what works with them. Bedside audits, understanding transfusions, training. It's the stuff we do. Like I say, I'm not here to tell us what we do for a living. I'm here to just recap what we do. So nursing relationships are crucial when thinking about patient blood management. And then, of course, patients, carers, families. We know through SHOT now that it's much more important, and nobody would dispute this, to have that dialogue now with families. Working at Great Ormond Street, everything we do involves parents and carers and guardians, and we have a fantastic young people's forum where some of our patients who have become young adults now sit on there and are a voice for our younger children. So they are a very great source of information. And indeed, when we do some SHOT work later on this year in patient ID, we're going to involve hopefully some of our young people to talk to us about that. And then our local and regional programs. Well, that's us, isn't it? That's the groups that we sit in within the TP world. That's today, that's the RTCs, That for me is almost all the stuff I do internationally with ISBT, but going on, because you soon find whether you're in Australia or whether you're in deepest, darkest South London, or not that south, but south for me, the principles don't really change. Things are very much the same. So moving on slightly here, we're going to talk about red cell usage because that's what people want to know about when it comes to PPM. So I'm not saying, and those can spot my picture in the middle of that, that suddenly Rachel Moss came into post in 2003 and red cell demand went down. But I think I was number 100 in the transfusion practitioner world, and there was a flurry of TPs that joined after me. So I really do believe that TPs had an impact. And we had, as you can see, Better Blood Transfusion 1, that was around the late 90s, and then Better Blood Transfusion 2 came along, and then all these teams were set up. NHSBT set up their hospital liaison teams. I think we had a much tighter control on a hospital transfusion team. Better Blood Transfusion 3 came out a few years later, and then, of course, PBM came out. So you can see that downward travel, and at all points in this, there are TPs. We are in the middle of this downward trend in blood usage. So we should take some credit for that. And I think this also shows another picture, but of course, ONEG, not quite so much. And so we know from all the information, and we've just had a talk about this, that we can do more with ONEG. So let's think about that. Because what I'm looking at today is where can the TP get involved? Now, I love this infograph, and NHSBT and their patient blood management website is seen across the world because it has some fantastic infographs. And this to me just absolutely sums it up beautifully. No more words or pictures are required. And again, I would give credit here. I will never steal anybody else's work. Again, the infographics are perfect. So as a TP, and Kat has just shown this fantastically, we can get involved, we can get amongst it, we can look at the demand, we can look at where we can make changes, we can think about retraining our ED staff, we can talk to our laboratory staff, we can think about using a local audit, we can look at protocols done. So as a TP, we can drive this. We're not doing the work. It requires us to work really closely with our laboratory colleagues, with our ED staff, but we're in there, we're amongst it. But we're engineering this project. So it's a PBM project that transfusion practitioners are in the middle of it. We're not islands. We all know that. I mean, I've never met a quiet DP in my life. All of us have to get out there and get to know people. And of course, we've been surveying this. So we've got some 2018 data showing us where we're using it, what's going on. So people like data. We all know if you're talking to a clinician, you have to go with data now. They're not going to listen to the, well, yes, but this is what we do. No, take data. Here you have data. And you can use this as a basis to look at O neg. So I think as a TP, for me, O negative, great project. Kat's shown that. There we can be in the middle of it and really affect some change. What about in the management of anemia? So this was written again by Linley and I and some doctor colleagues, all from Australia. I'm the only Brit, I hasten to add, in this paper. The rest are all Aussies, so I think I should have an honorary Aussie passport for this. But again, we looked at where the transfusion practitioner sits in anemia. What can we do? Where can we affect change? That's what the whole point of this is what can we do to help in the anemia world? And there's so many resources now about preoperative anemia. So unless you're living under a rock, you'll see all this. And of course, the NICE guidelines and the other guidelines, ISBT are involved in this. The World Health Organization have a lot to say on this. Interestingly, we're trying to look at it in children at Great Ormond Street, but it's far more complicated than you would ever believe because it depends on age and et cetera, et cetera, et cetera. Adults are far less complicated. But again, it's resources. So we go with information, we go with data. We can tell people that there is a problem. We can tell people that other centres are doing this. We can show what's being done. I love my PBM resources from HSBT and a flowchart. Who doesn't love a flowchart? A flowchart here that will show you which way to go. Yes, no, very straightforward. I have taken this from the Association of Anaesthetists. Everybody gets their credit. Again, very straightforward. In adults, children, more complicated, but it's something you can take to the surgical teams. It's written, it's done, it's ready-made. What we don't want to do is reinvent the wheel. And as I've said on more than one occasion, the great thing about TPs is what we love sharing. We'll share anything. Even today, lots of chat. Can we share? Can we share? Can we share? There'll always be resources for people that ask it. So moving on from pre-operative anemia and where the TP can be involved in that, what about iatrogenic anemia? And this comes up quite a lot, not just in children now. It used to be very much driven by children and pediatrics, particularly neonates. And neonates still, I think, the biggest cause of anemia is because we take so much blood from these tiny little babies to find out what's going on, and then we have to top them up. So we know there's a problem. But what can we do as a transfusion practitioner? Because people are not going to stop testing because we need to. So again, this time written by non-Australians and myself. I do collaborate with non-Aussies. And what we really push forward here is a partnership working. So again, as I said earlier on, find the nursing staff, work out where the high sample areas are. Think about a correctly labeled sample target. I did one years ago and I worked in another hospital on ICU just to see if we could make some improvements. Make it a risk and governance issue where they're aware of mislabeled and rejected samples and then ask for project support. The get it right first time is gaining some traction. Wrong blood in tubes. I'm sure we could have a whole talk on wrong blood in tubes because it's another one of my favorite topics. But we know from wrong blood in tubes that they're also a problem because we have to rebleed. So it's just finding where we can get in and amongst it, where we can make some differences, who will work with us, not being the one that does the work, but the one that helps bring the teams together. Wards, EDs, theatres, cell salvage we talked about earlier. That's another part where transfusion practitioners can get involved. We talked about the anemia iron clinics. We weren't running it, as Helen said. She just had oversight. That's perfect. That's what the TP role should be. And then work with the labs. I mean, what tests do need to be done? I know as an ex-ICU nurse, very trigger happy on my blood gases. Rolled a patient, do a blood gas. They've coughed, do a blood gas. So we can really think about what we can make small volume phlebotomy tubes. They're not always going to run on an analyzer, but you might be able to get a thin tube inside of a fat tube. Point of care testing, Denise mentioned the HemiQ. So there are things we can do. One of my favorite expressions is incremental gains. You're not going to change the world overnight. Nobody can. But if you can make small changes, whether it's in looking at your preoperative assessment anemias, or whether it's iatrogenic, or whether it's your own neg, you start to feel that you're making some impact and it gains traction. But going back to what I said about data, audits. Now, I know we all get a bit of audit fatigue, but don't underestimate the power of the national comparative audits that we do in the United Kingdom. One thing I have learned by going abroad, particularly in some of the bigger countries like Australia and the USA and Canada, is they're quite silo working in their geographical areas. So, for instance, Ontario is 1,000,000 miles away, both geographically it feels, but also transfusion way from, say, British Columbia, and they're very separate. If you go to Victoria in Australia, they have a whole Victoria Blood Authority, and that's not the same as New South Wales. Whereas what we do so well in the UK, because we're quite small, is have national comparative audits, have SHOT, have all this amounts of really good data that tell us where things are going on. So whether we're doing a local audit to look at what's going well, I'm a big believer we're not going in there finger wagging going, you're rubbish and you know you are. We're going in to say, actually, do you know what? You're the best hospital. You're the best ward in my hospital. So I'm going to work out what you do well and then tell everybody else what you're doing so great. Audits are our key because everything we do is data driven and PBM is data driven. When you look at all those the data, the pillars of PBM, what drives that and what the clinicians are looking for is data, improvement data, patient outcome data. We've talked about triggers. We've talked about the 15-minute rule. Where does that information come from? So it's all data driven. And that's what TPs can do so well. We can either do the audit or we can take the audit data from the national comparative and really use it to drive change. But, you know, I do live in the real world. Sometimes I think people think I live in this sort of fantastical, we'll do marvelous things and TPs are taking over the world. I mean, TPs are, in my view, taking over the world, one hospital at a time. I'm trying to take over one country at a time. But it's all these things. The NHS, how many of you were pulled away during COVID, and particularly the nurses pulled back because they just needed you to be on the wards. Staffing time, somebody leaves these days and your heart sinks because you know it's going to take you 6 months to get them through all the committees required to get the job back. So we know that, but I think it goes back to what I've just said about incremental changes. And I think, what's the name of the guy, the Sky Cycling Team chap? If we look at it as a whole and our hospitals as a whole and go, oh, we're really rubbish at PBM here, you would get that sort of slightly negative. But if you go, do you know what? We're not doing everything, but we're doing this and we're getting some data in that, and that looks good. And we want to do that. And actually, every time I go to the HTC, I mention that. And now one of the new anaesthetists, I love a new anaesthetist. They're always very keen because they want to make their mark in their team. One of the new anaesthetists is really keen. So don't think of it as a big PBM problem that a TP has to fix. Think of it as TPs. We are marvelous. We have so many skills. We really do fit in everywhere. Hemovigilance, audits, reactions, teaching, training, just telling somebody what's the right giving set to use, what the right Venflon is to use. That's where we do well. And so if patient blood management puts the patient right in the center of the transfusion process, then right there is the TP, because there's no other role in the whole of the transfusion medicine that looks at the whole thing and sits with their fingers in all those pies like the TP role. And that's what we do well. And that's why PBM and the TP are a great fit. And that's me done. Thank you.